Good evening, everyone, and thank you for joining us for tonight's Woo You event with Dr. Shalu Pal, and she'll be discussing treating dry eye with more than drops. I'll be your host tonight. My name is Dr. Ariel Sorenzi. So it's my pleasure to introduce our speaker, though you guys probably already know who she is. Dr. Pal started and runs a 5 OD practice in Toronto, Canada, which is home to every subspecialty within optometry. She's a co-editor for Mastering Myopia, Myopia in Practice, researcher and a co-founder of the Canadian Contact Lens Academy and the Staple Workshop Program. Dr. Powell's lectures globally and continues to be published while working with industry partners for the betterment of the profession through education. She's been honored with the CLCS Achievement Award for educational contributions to the industry and awarded the Legends Award by American Optometric Association. Dr. Powell was the first Canadian chair of the AOA Contact Lens and Cornea section and the first Canadian selected as a U.S. Contact Lens Institute visionary. She recently graduated from the Global Healthcare Leadership Program from Harvard Medical School. So Dr. Powell's practice in Toronto is just pretty legendary practice, and it's really cool that we get to hear from somebody that's, day in and day out doing the dang thing, and it's so refreshing to hear from practitioners that are, in the thick of it and can give us really great advice and practical knowledge on all things dry eye and all the other things that you speak on. So thank you so much for speaking with us tonight and sharing your expertise.
Thank you so much. I'm happy to be here.
Then here are financial disclosures, all of which have been mitigated. So I'll have you take it away from here.
Thank you so much, Ariel. Thank you everyone for joining. I'm excited to be here with you. Guys, I'm going to be honest. I have a lot of slides that I want to get through because I have a lot of information that I want to share with you. So I am going to talk fast. I'm going to go fast and I'm going to go through a lot because I really want you to know the journey that I went through to start my dry eye practice. It was very much a process. It was years and years ago when I was starting to fit scleral lenses. After I figured out how to fit those with respect to irregular corneas, I'm like, what else can I do with these scleral lenses? And dry eyes was the next logical step. At the same time, Allergan brought one of each of us from each province in Canada together as a group and said, look, we're going to teach everything about dry eyes, and then we want you to help other people to start their dry eye practices. And all of us were very green. None of us really had dove into this specialty yet, but we were very eager to learn. And what was really funny is I sat there amongst the group for almost a year, and I was like, I don't know how to start. I really don't know how to start. I was so lost. And everyone's like, I started this, and I started doing this, and I started that. And I was like, I don't know where to begin. Like, I feel so overwhelmed with everything I was learning. And this was like 15 years ago. So you can imagine, like, compared to everything we have today, back then I was so confused. And so I said, okay, all our reps are saying, take a questionnaire and ask every single person in your practice how to use, or give them the questionnaire and ask them, fill it out and let's see what happens. And so I did that. So every patient that came through, I started handing them a questionnaire, and my patients started getting mad at me. They're like, what are we doing filling this out? I don't want to fill out more paperwork. And I was like, that's not working. Okay, why is it working in all these other practices and my patients are refusing to do this? It's just my patient population. So I then started to figure out, well, like, let me start gathering some information. Let me start talking about dry eyes. And then I was like, well, how am I going to treat this? And I started looking at all of these flow charts, and I literally felt like I was pulling my hair out because I'm like, my patients are not fitting into any of these proper neat boxes that they're supposed to. And I'm like, I'm so lost. When our patients stand in front of their counter, and they're looking for an eye drop and they're so confused, that's literally how I felt looking at all these algorithms. I'm like, I'm so lost. I really don't know where to begin. So the things that I needed to figure out, I'm going to talk to you about, but I want to show you my practice today. So this is what my practice looks like. And so where I came, I finally figured out, I kept testing new things. I kept learning. I kept really hanging out with people that knew lots about dry eyes. And I just kept educating myself, trying new things and revamping and going back and testing it. And I figured it out, and I figured out a strategy for my office. And I'll show you a couple of other photos here. So here I have two dry eye treatment rooms now. And I'm going to talk about the different things that I've brought in. We do have a skincare line that goes along with some of the treatments that we do for dry eyes. What I really had to figure out was, what is dry eye disease? Where is it coming from? How do I treat my patients that are in my practice that are different from other places and other practices? And how do I differentiate between patients that are referred to me versus my everyday primary care practice patients? Because I was not going to be a doctor that was just going to have only a dry eye practice that everyone was referred to me. Like, I had my own patients that I had been seeing for years. I also wanted to figure out all of the data that I want to collect on these patients. Who's going to do that? It's going to be me. It's going to be my staff. And then once I have all of this, how do I create a protocol, and how do I get my patients to actually proceed with those treatments? So all of those questions that I had to figure out, that's what I'm going to go over with you today and show you how I worked on that. So figuring out where dry eye disease came from, it's a really important to understand the root cause of, is it an aqueous deficiency? Is it coming from a lack of volume? Is there a problem with the lacrimal glands? Is it because of a distribution problem, that our blinks or our eyelids are not working properly and we have the tears, but they're just not being spread properly? Is it an evaporative problem? Is that coming from the meibomian glands, which is causing poor tear quality, poor tear stability? Or is it actually not dry eyes at all, and it's something else that it's mimicking dry eyes? Is it a BV issue? BV issue? Is it a conj issue? Is it floppy eyelid syndrome? Is there something else that's making it look like it's dry eyes, but it's really not? So these are the things that we've got to figure out, right? Because you can treat things symptomatically and just act like band-aids on top of things, or we can actually really try to get to the root of things. Understanding what the root is really important. I'm going to show you that. So I kind of divided up everything that I wanted to gather from our patients, and I divided between what are my staff going to do versus what am I going to do. So I'll go through everything that today, as of present day, I get my staff to do. And the first thing is the case history. So I have them review their health, their medication, what dry eye treatments they're doing. Have they had any surgeries? I want to know about their contact lens wear, and I really want to know about how much time they're spending on the computer. This list is a list of all the things that can impact our eyes with respect to dryness. Then I'll have them do a questionnaire. Now, checking osmolarity, I used to do Inflammadry. I don't do Inflammadry anymore because I find that all of this is stemming from some form of inflammation, and that piece of information didn't help me. So I don't do that, but osmolarity I found very helpful. So our osmolarity range should be somewhere between 280 and 295. If it's higher than that, you got to be thinking dry eye disease. If there is a difference between the right and the left eye of more than 8 units, I want you to be thinking something's going on with the lids. And if it's lower than 280, 290, it's 295, and you're saying, well, it's not high. This doesn't look like dry eyes. What else could it be? Let me show you what else. I also have my staff do topography, so I can look at their corneal health. Is there some sort of surface disease that's being impacted that I can see and look for improvements? So going back to the question about osmolarity, if we have a normal osmolarity reading that's equal to our blood values, these are some of the things that could be there that are not dry eyes, but the patient is feeling like there is dry eyes. So one of the advantages of doing osmolarity is that you're going to get a sense of, am I dealing with true dry eyes, or am I dealing with something else, right? So look at all of these conditions. There's a lot. There's even more. So all of these conditions can be creating the symptoms of dry eyes, maybe even some of the signs of dry eyes, but your osmolarity test will say, hey, this is not true dry eyes, there's something else going on. So I found this test to be very helpful for me. So I do this test for sure. My biography is something that when we first brought it in was very new. But look at this. These are all the mammographers that are on the market right now. And I pulled this list about 6 months ago. There's probably more on this list now today. But mammography is super important to be looking at. And one of the things that I do is I do mammography on every single one of my patients. This study I want to show you, it's the DREAM study. It is a really good study, and I took these images from it, which really helped to describe what am I looking at when I'm looking at these glands? How do we talk about what is actually happening? Is there atrophy? Is there ghosting? What do these vessels actually look like and what do they mean? So these slides, I will hand these all to you and get these to you for sure. But this study in particular, I find really helpful to just help with the wording and understanding of what's actually going on with the glands. This is a handout that I have in my office. And how I use this particular document is I use it for my office communication with my staff. So, and my patients. So when I do my biography and I'm talking to my patients, I'll describe a few things. And they give me this puzzled look, and I'll show them this, and I'll say, look, this is a perfect setup right here. When we look at this top image, when we look at this second image, we can see that there's more damage, and these are really, really damaged glands here. But I also use this when I'm talking to my staff, because when I take my patient to my staff at the front, I will say, hey, they have a level 1, or they have a level 2, or they have a level 3, or I might say a 1.5, which is in between 1 and 2, or a 2.5, which is in between 2 and 3. So the staff knows right away what I'm talking about when I describe the glands. And when we start talking about what our treatment plans are going to be, I use this tool to have that communication. Non-invasive tear breakup time. So my topographer also does this, and I have my staff do this. So it's nice to have a consistent measure of tear breakup time opposed to doing fluorescein. You can still do fluorescein. It's a very important test because it's looking at your tear quality and how good your glands are. NeuroLens is another test that I have my patients do. This is obviously something that I brought in newer into the office, but years and years ago, Dr. Paul Karpecki said to me, he's like, you know what, if you've tried everything, and you are just pulling your hair out because you can't figure out why your dry eyes is not getting better, he's like, I figured out that it's usually a dry eye, a VT issue, a binocular vision issue. And so I'm not a VT person at all. So I have two VT people in my office, thankfully, that I can refer to. But to think about this, where I use my NeuroLens is as a clue as to, hey, is there something with respect to BV that I may not see that this will give me a quick guide into saying, hey, think about this because maybe not all your symptoms are dry eyes. Maybe they're coming from a BV issue and vice versa. If this pops up, maybe I'm going to think about, because there's a questionnaire that talks about lifestyle questions. If some of those questions are high, that also points me in the direction of, hey, maybe I should be thinking about dry eyes as well. So I get all of my staff to do all of these tests, and then I put them all together on my desktop and I start reviewing them. There is different software out there that will help you consolidate all this information into a nice platform. I don't have that. You don't necessarily need that, but it is helpful. But I bring up all the information on my desktop, and I'm going to show you the setup that I have in my office. So here's my office here where I sit at this computer here. I've got my medical records here, and whatever I'm looking at the computer, my patient can see on the wall there. So every test that I'm going through and talking about that they have done, I'm showing them to them on the wall so they can follow along. I really think it's important that everything that you do, you show your patients. It's really helpful so that they can actually see what's going on, and it helps them to understand what it is that you're talking about. Before I had this nice setup, I was using my iPhone to take pictures, and I would show them right on my iPhone. And, I would hold things in front of them. On Amazon, you can actually find these special types of mounts that you can attach to your slit lamps. You can get special devices that will attach to your slit lamp. So you don't have to go fancy. My slit lamp camera that I finally got was a birthday present 2 years ago, which I was so excited about. It was like best present ever. but you can start simple. And I was just using my iPhone to gather. In this photo here, what I'm doing is I'm using my 20 diopter lens, blowing up her eye, and then taking a photo through the 20 diopter lens. Got very creative with how I was trying to capture pictures here. All right, so what's my role? What's our role in all of this? Your role starts literally as soon as you see the patient and you start looking at them. You can see I've got 13 steps here. Let's go through all of them. The ultimate goal of all of these 13 steps is to figure out what are the signs and symptoms of your patient. Is it a chronic episode? Is it an acute episode, or is this like waxing and waning and episodic? And you got to understand what is the motivation of your patient. Okay, so these are really important. What your case history is going to help you figure out, and what the purpose of all the info gathering is about. When you're looking to treat, I want you to think about these things. What are my short-term solutions versus my long-term solutions? What are things that I need to work on structure versus function? And am I going to put a Band-Aid on this, or am I actually going to do a deep root repair? Okay, so these are the things that I'm thinking in my mind, and we're going to come back to this slide later. But when you're looking at a patient, it starts with looking at them, looking at their hands, looking at their eyes, looking at their facial features. What is present? You can see rosacea coming at you from miles away. But if you don't look at the patient, you're not going to see it. And I'm telling you this, I want you to actually look at your patients, because they're going to give you so many clues about inflammation that is present, asymmetry between the eyes, redness, soreness. I've trained my staff to be able to do this. So when they hand off a patient to me and they bring me a chart, they'll say, hey, make sure you look at their lids. They're really, really red, right? They're paying attention. Next thing I'll do, have the patient close their eyes, and I'm going to look for nocturnal lagophthalmos. And it's really simple. I use my pen light. So I have them close their eyes, relax in the chair. I turn the lights out, and I said, I want you to imagine that you're sleeping or that you're relaxing on a beach. And then I said, I'm going to bring a light close to your eyes, and I'm just going to shine a light on your eyelids. And I use that pen light and I shine it right on their top lid. And I look to see if any of that light is creeping through their lower lids. So do they have a full closure or do they not? If they have a full closure, no light's going to come leaking through. But if they don't, and there's a little bit of a gap, that light is going to shine right through. So you should test it. It's a really easy way. If you don't have a mebrographer, you can also use your pen light to invert the lower lid and use the pen light underneath, or your transilluminator underneath, and you can get a little bit of a view of the meibomian glands that way. Just some tips here. Next, looking at the glands, take a really good look at the glands. What am I looking for? Well, now that we have ways to treat these glands, I'm looking for a lot. I'm looking at the meibography. I'm looking at the lid margin, at the lashes. I'm looking for telangiectasia. I'm looking for plug glands, right? I'm thinking about that dream study and thinking about, okay, what do these glands look like? I'm also looking at the lid margin. Are the lids flopping over? What does that apposition towards the lids look like? Are the lashes irritating the eyes at all? A lid laxity test is really easy to do. And Dr. Perriman described this to me, where she just pulls on the lid and lets it go. And if the lid bounces back, it's got good laxity. If it takes really long to bring back, that's something that she repairs and works on, so that you've got good apposition against the globe, because that can create problems with epiphora and lids and tears running down your face and just feeling uncomfortable. And then obviously looking for that redness at that lid margin. Expression. Because I do, so I didn't tell you this part, but I do meibography on all of my patients, and I also do expression on all of my patients. And the reason I do that, and we'll talk about it in a bit more, is that I have set a different scale of what am I going to do for my primary care patients and what am I going to do for my patients that are referred to me. For all my primary care patients, I do meibography, and I will do an expression on them. And I either am using that Corb evaluator, because that gives us even pressure along the lid margin, or I'm going to use my thumb to just push and see what's happening. And when I tell my patients what I'm doing, I'm like, the purpose of your lids and your blink is when you blink, your top and bottom lids are going to hit each other, and those oil glands are going to pull oils from one another. Think how gentle a blink is. Blink yourself, feel how gentle it is. When we push on a gland, we're putting a lot more pressure on that bottom lid, top lid, than what a blink is. So if we're pushing gently with our finger and nothing is coming out, there is no way that anything is coming out when they're blinking. And I will describe that to patients. And so they help to understand what the purpose of a blink is. I don't use forceps. A long time ago, I was told to be very careful not to damage my bone glands, and that stuck with me. So I'm not someone that likes to squeeze the glands too hard, and I don't like to do probing of glands, and I know there are people that are there that do that. That's just not what I'm comfortable with, but we can always refer out for this type of technique. Looking at the lashes, we have heard it lots over the last couple of years about looking down. Have our patients look down, close the lids so you can take a look properly at the lashes to see what's actually happening. When you look quickly with your slit lamp straight ahead, you may not see what's actually happening. So have all your patients tomorrow look down and look to see. You'll be surprised at how much bleph and Demodex that you're actually going to find. Then you're going to check their blink. You may have a fancy tool to measure blink, or you just sit behind a slit lamp and you chit chat with your patients and you just watch them naturally as they blink. And, I've told patients, I'm like, okay, you want the good news and the bad news? And I'll tell them, I'm like, you know what? It's actually kind of sad, but you've got really wimpy blinks. And they were like, hey. And I'm like, it's true. You're not giving me a full blink. Give me a full blink. And I force them to give me a full blink. I'm like, that's a complete blink where those lids are hitting each other, but you're just doing these wimpy blinks. So I know I have to teach them how to blink better. And then conjunctival chalasis. This is really important to look for because this is something that will irritate. It's a mechanical irritation that's going to cause irritation to the cornea. And this extra tissue, so tissue becomes flimsy, unfortunately, as we get older and with allergies. And that tissue can just start to fold up and irritate the cornea. And that irritation can feel like dry eyes. I've been seeing this for years, and it took me a while to find a surgeon who's like, yes, I agree with you, and I can remove that extra tissue and it'll help your dry eye patients. So I refer more for this than I used to because I actually have a surgeon that's there to actually be able to help me. Tear volume and tear length. This is looking for the quantity of tears that are actually present. And do we have a lot of tears? Do we have a lot? Or are we not? Now we think about the Schirmer's test. I do not do the Schirmer's test in office unless someone's referred to me to rule out or to rule in Sjogren's. So, I heard something really great on the weekend where someone said, the most important reason to do a Sjogren's test and to do a Schirmer's test is to actually send a report back to the referring doc and to say, here's what the Schirmer's test tells you, but here's actually everything else that I learned about the patient that's actually more valuable. And I want you to know what else we're doing besides just that Schirmer test. The tear lake is really important when it comes to contact lenses, and I'm going to talk about that in a little bit more. Corneal staining and conjunctival staining. Your vital dyes are so important. What this is going to tell you is what's going on. I had a lady come in and she was like, oh my God, my eyes are burning. They're burning. They're burning. There's something wrong. I've got this terrible infection. And, I stained her eyes and she had all these little scratches on the front of her eyes. So there's something under that lid. And there was a little foreign body under that lid that she was just scratching her eyes with. Our stains are so important. It tells us so much about the severity of the dry eyes. Is there pain and irritation on the cornea? Is it on the conj? And this is helpful for us to know, what are we treating? Are we just treating the cornea? Do we need to be thinking about the conj? Where is the dryness that's present? And let's put the right tools to the area where things are found. Lid wiper epitheliopathy is really important. And so many of our contact lens patients have this. Contact lenses, there's a section in here about contact lenses. Contact lenses create a lot of problems for us and for our patients. And looking for this is important. So how do you find it? I think the most important thing about this slide is that studies have been done that show that not only putting one drop of your vital dye in, but two is actually really important. And you're all like, I'm not even doing one. And I'm saying, I'm asking you to do one, but if you can do one, try and do two because two's even better. And when you wait a little bit longer, you're actually going to see a little bit more. And so this is done with lissamine green and this is done with fluorescein. And you just get to see a lot more of what's actually happening. So think about staining. Think about also doing two installations instead of just one. The Jones test, this is if you're looking for obstruction, right? This is where after all your testing you've done, you hand a patient a Kleenex and you're like, okay, blow. And then they're like embarrassed because they don't want to blow their nose in front of you. But you're like, it's okay, go ahead. I'm doing a test here. And then I'm like, you don't need to show me, but I want you to look. Do you have yellow that's on your Kleenex or is the Kleenex wet? And if there's no yellow and the Kleenex is dry, then we know that we've got an obstruction there. But so it's a quick and easy test. Corneal sensitivity. I want you to listen to this because this was a game changer for me. Looking at the cornea in a different way is really, it was really exciting for me to learn this. And Dr. Amy Now taught me this. So a neurotrophic cornea is a cornea that doesn't feel anything. So we've learned in school about creating that cotton wisp and touching the cornea. And if the patient doesn't feel anything, then you know that they don't have any sensitivity on the eyes. With these patients, you've got to be very careful because they could scratch themselves and they wouldn't even know it or feel it. I have a lot of these patients in my office. I give them scleral lenses to wear, and I also talk to their family members because, I had some patients come in who were like, yeah, I'm not seeing so great. And, I'm like, do you feel anything? They're like, no. And then I look at their eyes and their eyes are completely scratched out. They just ripped that epithelium off the front of their eyes and they had no idea. And it was their family member that said, your eye's not looking good. You should go in. Who was it? Dr. Nichols was the one that shared with me that some people are using dental floss and they're using dental floss, just the tip of it to poke on the cornea or cutting one of these and lifting up that little tip of that brush in these, dental picks to poke on the front of the cornea as well. Corneal hyperalgesia. So what's this? This is something when someone is extremely sensitive to pain. So how do you figure out if someone has this? Well, again, Dr. Nausch taught me that when what you do is you talk to your patients and you say, hey, I want you to tell me right now, how uncomfortable are your eyes? Before you've done anything, just say, how uncomfortable are your eyes? And then you put a drop of Muro in their eyes. And when you put that drop of Muro in, then you say, how did that pain level change? And if that pain level went up a notch or two, like initially when you put the drop in, they're going to be like, oh, it burns because, right, it's a salt-based solution. But when you wait a minute or two and you let it calm down and you're like, okay, how do you feel now? And if they're like, well, it's maybe a two instead of a one, or I've moved up one level higher, then you're like, okay, your cornea is it's a normal sensitivity level. But if it goes 2 units or higher than 2 units, I want you to think that, whoa, you're super sensitive. Your eyes are just like overacting. Those receptors are just oversensitive. So the things we need to be thinking about is we need better tear films. I want you to be thinking about LipiFlow. I want you to be thinking about biologics, serum tears, or PRP, or thinking about scleral lenses that are going to help protect, or amniotic membranes, or maybe we need more stronger steroids because that cornea is so super sensitive. Corneal neuropathic pain. So now that you have the Muro in, I want you to throw a drop of proparacaine in the eyes. Now, proparacaine, we know, should numb everything. And if it numbs everything, you know that all the pain that they're feeling is on the front of the eyes. But if they still feel their pain and you've numbed everything, it's not the front of the eye. We're talking about something here that's causing their pain, and it has nothing to do with the eyes. I can't tell you how valuable this test is to be able to say, this isn't me. I'm not going to be able to help you. I actually need to refer you to a pain clinic because your pain is not coming from your eyes because I've just numbed your eyes completely. You should not feel any pain anymore. But if you're still feeling pain, this is coming from somewhere else. So things like LipiFlow are not going to help because the pain is not here, it's here. So you've got to refer them to a pain clinic. So remember I talked about my patients versus patients that are referred to me? What I just described is very much a full comprehensive dry eye assessment that I do for my patients that are referred to me. So patients that are referred to me, I've got a lot of time that I can go through all of these steps with them. My primary care patients are slightly different. My primary care patients, every time you ask them for another amount of money besides their primary care cost, they're going to say, no. And I'm going to lose people along the way. And I kept losing people. And I'm like, I know that all you people are suffering for dry eyes and I want to talk to you about it, but you won't let me do these tests because you don't want to pay for it. So I just said, forget it. I'm just going to do it on these tests on everybody. So I do my biography on all my primary care and I do neural lens on all my primary care patients because I want to know what's going on with you. And I'm not going to necessarily do a full dry eye evaluation, but if I see a couple of things on those glands, I'm going to start having some primary conversations. Hey, this is what I'm seeing. I'm going to show them on the screen and I'm going to talk about what I'm seeing and what I want to do and what the problem is. And I'm going to look at their motivation of, hey, is this something that we're going to keep talking about? Should I bring them back for a full assessment? They may say, yeah, I didn't realize that eyes watering was actually a problem. And then I'm going to have more conversations with them. But that my biography that I do it's starting the conversation for me so I can plant seeds and I can identify more patients and then put them into the treatments that they need. The referred patients, those are the ones, right, that they have tried so many things with so many different people, and now they've kind of the doctor that's referred to me and said, I don't have any more tools in my toolbox left. I need you to do more. And that's when I'll do that full dry eye workup and spend more time diving in deeper, and we'll just do a little bit more. Okay, so we've gathered all this information. Your staff have gathered all this information. We've gathered all this information. And now what do we do with all of this? It goes back to this, right? Like, oh my God, what do I do with all this information? What box do we fit in? And when we look at the DEWS 2 report, we've got these nice step-by-step approaches, but this didn't work for me either because rigid scleral lenses is my passion. And I do that. I want to do that at step 1. And this was at step 3. So I'm like, even DEWS 2 doesn't work with me. So how could I make this work for myself? So I came up with this strategy of, with everything that I see, I'm going to treat. So if I see blepharitis or Demodex, I have my different procedures. They're either at-home procedures or in-office procedures. When it comes to my meibomian gland dysfunction, there's things you can do at home. There's things that you can do at the office. There are things that are going to impact structure, and there's things that are going to impact function. And we're going to talk more about structure and function with respect to my meibomian glands. But I'm thinking about, what do I see? What can I show my patients? This is what you have, and this is what I'm going to do to treat it. And you could do this at home, and the faster treatment is what I'm going to do in office. They have a choice. They can say, I don't want to do that stuff in office. I want to start with what's at home. No problem. But I'm going to fix each and every problem that I see. So whatever it is that I'm seeing, if I see issues with the cornea, I'm going to be thinking about the different things that I need to help fix the cornea. And I'm going to be thinking about that nocturnal leg ophthalmics. So I'm going to go through these different parts of the eye and say, hey, at this part of the eye, this is what I see, and this is what I'm going to treat you at home with. This is what I'm going to recommend in office. This part, this is what I'm going to give you for homework, and this, and what I'm going to see you. And I put this all together for a report with them. Remember, we talked about what is that root problem? What is that issue that is causing that dry eyes to begin with? I know there's inflammation. Where is it? What is the damage and where is it present? And how do I get rid of it? I'm also going to be thinking about sending and working with their primary care doctor for medical testing. I want to be thinking about food and diet. I talk a lot about food and diet because we can impact our dry eye patients with modifying and helping them modify their diet. Am I going to come up with a diet plan for them? No, I'm not a dietitian, but I'm going to plant the seed about how there are foods that have an anti-inflammatory impact that we should look into for you. And changing your diet and doing food sensitivity testing can help figure out what's causing inflammation in you, in your body. And I will send them off. So I'm giving them more pieces of information that are going to help them to get to the root of the problem. Remember this slide here where we're talking about what's our goals? This is really important. And we're thinking about what are those underlying reasons why we have dry eyes. We're trying to bring it all together, right? Once I have all that information, what are my short-term things? How much pain are they in? I want to give them a quick relief to make them comfortable. And then what's that long-term strategy that's going to get to the root of the problems? Structure and function, we're going to talk about it again. And bandage versus repair. Am I just giving you a quick band-aid, or I'm actually trying to repair something? Am I going to give you some artificial tears that are going to be slow and just give you temporary relief? Or are we going to start you on cyclosporin that's going to go deeper, longer, have more of a repair impact? One's short term, one's long term. When I use these terms, it helps patients understand what I'm doing. Short-term band-aids, long-term repair, structure versus function, at home versus in office. It helps me differentiate the different types of treatments and helps it keep it clear for the patients as well. But it's a lot, right? So I put together a full report from beginning to end, from the start of the morning till the at when they go to bed. I have a full day plan. And I tell them, you're not going to be happy with me because I am going to do a lot. I am going to do a lot and put a lot and expect a lot for you, but it's not going to be like this forever. If we do all of this and we hit this hard, then the next time I see you, we can hopefully cut back some of these and we can reduce some of the things that you have to do. I use my staff to help me with this because then I take the plan for them and then they go through all of that. Because we say it all once, patients have forgot half of it, right? More than half of it. So then I have my staff go through it and review it again and pull the products that they need. Let's talk about drops and contacts. Okay, so what do we know about contact lenses? Contact lenses cause dryness. Dryness is the number one problem. What else do we know about contact lenses? Contact lenses are about 100 microns thick, and this data is all coming from Dr. Lyndon Jones and his work that he's done. That tear film, that lake that we look at, that tear film, it's about 5 to 7 microns. And what we do with that thin tear film is we put a huge piece of plastic in the middle of it, and then we split that thin 5 micron tear film in half, and it has to go half on top and half below. The contact lens completely destabilizes the tear film. It's discomfort is the number one reason why we know that patients drop out of contact lenses, right? So what else do contact lenses do? Here's a whole list of damage that they cause. They cause mechanical irritations. They cause lack of O2 coming to the eyes. They disrupt all of the beauty of the epithelium. They cause lid wiper epitheliopathy, causes MGD, it causes Demodex. Like, why do we fit contact lenses? We do because our patients love it. I'm wearing them right now. I love them. We do this because our patients really enjoy this, but we have to understand that there is a negative impact to them. So we also have to remember that there's two parts to this relationship. There's the cornea and there's the contact lens and cornea. And when we are talking about contact lenses and someone has an irritated eye because of contacts and their eyes are dry, we always do this. We always say, oh, I'm going to get you a different brand. I'm going to change the solution. Let me try it one day. Let me try. But you got to remember to look at the eye itself because it's a relationship between the two. And if you're not looking at the eye, this is never going to be a good relationship. I want you to also think about being proactive versus reactive. I take a very proactive approach in my office because I want to make sure that we don't end up in a situation where people are streaming tears, uncomfortable, get lost out of their contact lenses. So what I do is I do things the same right from day one. When I start a patient on contact lenses, I will tell them, okay, good practice habits. If you're going to wear contacts, I'm going to have you use artificial tears twice a day. And I have them start from day one using moisture drops. And you're thinking, they don't need that. They do need that. They need that for their long-term health of their eyes. They need that so they don't run into dryness. They need that because that's the practice that they are going to get started with. And those are the habits they're going to build from day one. And it is going to be easier for me instead of I've been wearing contact lenses for 5 years and not have an issue. And now you want me to change my routine. If the routine is already there, it's going to be proactive and prevent so many issues. difference between rewetting drop and artificial tears. I think this is a really important conversation to have because patients come with us and say, hey, I'm using this. This is a great eye drop. Why are they using that eye drop? Because it's $10. And the eye drop that you want them to use is actually $20 or $30 or $40 or $50, right? Well, what's the difference between these two? Well, the difference is one's a rewetting drop and one's an artificial tear. Do we know the differences enough to be able to explain them? We should. A rewetting drop, the purpose of a rewetting drop is to not help the cornea, it's to help the contact lens. So it is working on rehydrating that contact lens. It doesn't care about the cornea, it cares about the lens. Think of a lens that's dehydrated. The lens is saying, I'm dehydrated, I need moisture. Where do I get it from? Let me pull it from this eye that has lots of moisture and let me replenish myself by pulling away from the cornea and from the ocular surface. That's what contact lenses do. So when you rehydrate the contact, you're saying, leave the cornea alone. Here's your own moisture. That's what it does. But there's nothing in there that actually repairs the corneal surface or works on the cornea. From an FDA standpoint, a rewetting drop is a medical device, okay? A medical device just like a contact lens is. So it's okay to use these medical devices together, the contact lens and the rewetting drop. Here's some more rewetting drops. When we talk about artificial tears are different. These artificial tears are designed to repair the cornea. They have so many more ingredients in them that are designed to protect the cornea, to protect the evaporation, to protect the ocular surface. This is a different vehicle altogether than just an artificial tear. Being able to explain these differences to your patient is really important because now they can understand, why am I paying more or less for the different drops? An artificial tear is actually regulated by the FDA as an ophthalmic drug. Okay. An ophthalmic drug you can't put on on top of a contact lens. Okay. So when they say, hey, you can't use these on top of the contact lens, and then all of us are like, well, we're going to try to make sure and see, and we'll test it on our own eyes, and we'll try it on top of the contacts. We're like, hey, it's fine. It's because by FDA standards, artificial tears have so many ingredients in it, and they're classified as an ophthalmic drug. And technically, you can't put ophthalmic drugs on top of contact lenses. Okay, just a little bit of an understanding of the differences between the two, because I want you to have the words to be able to explain to your patients what are the differences in all these drops, because there is a difference. And I never want you to be one of those docs that open up a drawer and just say, okay, try this one, like randomly choosing. I want you to have an understanding of what's different in them, right? Talk about scleral lenses. Scleral lenses, my passion here, there are so many benefits to scleral lenses. And one of the big benefits is dealing with dry eyes, right? That tear reservoir underneath that contact lens will really help you in an immediate reduction in dry eye symptoms. So when you're talking to your patients and they're sitting there blinking in front of you, or they're like, yeah, my eyes burn, or I get this sharp sudden pain, or when you're doing your refraction and they blink and they're like, oh, hold on a second, my eyes, like, wait a minute, I can't see it. Now I can see it. You know they have dry eyes, right? Scleral lenses are going to help with that. Someone that doesn't want to put drops in all the time, that wants that constant bath. If you've never had a scleral lens on your eye, come to one of our workshops, go to a workshop, put a lens on your eyes and feel what it feels like to have that constant bath on the eyes, because these have an incredible ability to make someone feel great right away. It has long-term benefits as well, to make the eye not so red, to heal tissue, and to get rid of some scarring, which is really awesome. Couple of things about scleral lenses. If you're going to fit scleral lenses, clean this all up before you get started, because you don't want to put a scleral lens on top of this junk, because all that's going to get underneath and trapped under the lens, and now it's going to have nowhere to go but to start irritating the cornea. So make sure you clean this all up. When you have scleral lenses and dry eyes, if you don't clear all that stuff up, all the complications like build up on the front of the eye, fogging and front surface debris, all of that can come from having dry eyes. You want to set up good baselines before you get started. Look what the cornea looks like. Stain the eye so you know what you're starting with. And then create these baselines so you know that you can track things. When I was talking about scleral lenses helping with scarring, I'm going to show you a case where I had a patient that had improvement with this. So I'll never forget this one patient. So he was sitting in front of me, and literally, this is what he was doing. He was blinking nonstop. And he was a Sjogren's patient, and he was doing so many different things. And he's like, someone told me to come to you, but I don't think there's anything that you're going to be able to do. I put a scleral lens on him, and he looked at me and he's like, I don't feel uncomfortable. And he goes, I'm not blinking, am I? And I said, you're not blinking. And it was just life changing for him because we instantly gave him relief. Now, when we talk about scleral lenses, something else to think about with respect to dry eyes, and we're going to talk to you about looking at the patient and staining the conj and the cornea. I had a patient that came in and she's like, I've seen 3 doctors. I've been fit in scleral lenses. I had IPL treatments and RF treatments and all these different things, and nothing was working. It's because the scleral lens was too small. Needed her to go bigger. I needed a bigger lens that covered more of the conch because so much of the eye was exposed that that's what was the problem for her. It wasn't that there was anything wrong with the current scleral lenses. They were fit great. They just needed to be bigger. So I want you to think about importance of diameter with respect to scleral lenses and that first step of staining the conch to make sure. This was that patient that had that front corneal scarring. And when he had so many surgeries done to get rid of that scar, but his lids were not closing, right? And we just had exposure keratitis basically. And when I put a scleral lens on top of him, slowly over time, it took a few years, but over 2 years, we were able to improve that scar and improve his vision from 2040 to 2025. Talked a little bit about bleph already, but let's look a little bit more. Remember, look down. You've got lots of different options of how to treat this. Your job is to figure out what's the right one for you and what makes sense. Combinations, what is it that you're trying to get rid of? Are you having stuff that's stuck on there? Are you wanting to do at-home treatments or in-office treatments? The best advice I can tell you is no matter what it is that you are prescribing, have it in your office. Have it in your office. You're not going to get rich off of these products, but you're going to make the life of your patients so much better because when you say, I want you to do this, 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 and this, you're going to just be able to grab it all off the shelf and give it to your patients. If you do in-office procedures, BlephX or Zest, either one, have a protocol. And our protocol, I don't do this protocol at all myself. My staff do this. They spend an hour to an hour and a half doing this full cleanup. Think about when you should do this before LASIK, before cataract surgery, before you do IPL and RF treatments. These are before you do a scleral lens fit. This is when you want to be thinking, I need to make sure to get rid of all of this stuff. You have stuff in the US that we don't have in Canada yet. XDEMVY is not here yet, but this is a game changer for you. And if you hadn't had a chance to try this, I want you to go and try this because I've been hearing wonderful things about how this is really helping with blepharitis and Demodex-induced meibomitis and just really helping to get rid of that Demodex. You know, the claim is that this is going to get rid of it, eradicate it. So try it and let me know how it goes because I don't have it yet. Remember, we were talking about those glands, structure versus function. Okay, structure is when you're looking at those glands and are they long and tall and full? Do they match that level 1 category or are they short and stunted or falling over or full or really thin or all clumped together? The structure, do they have good structure or not? If they don't have good structure, hot compresses and massages at home, IPL and radio frequency will help with structure. What about function? When we do that expression, is stuff coming out? They could have great structure, but the function is poor. So what are we doing? We need to get all of that oil out and we need to get new oils in. So you got to be thinking about hot compresses, IPL, radio frequency, lipoflow, expressing, lid scraping, using omega-3 cyclosporins, heating up those glands to get rid of that stagnant oil that's in there so you could get the function to work better, right? Very easy to have conversations when we talk about structure and function because you now have, I have a structural problem and this is what fixes structure. It's slow. This does not happen overnight. This can take 6 months to a year for you to see structural changes, but you have something that you can do. Functional changes are faster, but they still take work, right? But again, very easy for your patients to understand what's the difference between the two. IPL. You guys have heard a lot about IPL, but just reviewing some of the advantages, there's a lot of things that IPL can do. Remember, it's targeting pigment. So there is pigment in the skin, there's pigment in blood vessels, there's pigment in the exoskeleton of the Demodex. And these are all the areas where you're going to be targeting with IPL. So you can help with getting the meibomian glands to function better because they're going to melt the meibum and we're going to release it. You're going to improve collagen synthesis, which is going to help with the structure. You're going to reduce inflammation, right? So IPL works on both structure and function. I'm going to go quick. There's so many candidates. All of these images are all people that are great candidates for IPL. I'm going to show you some cases here. Rusty, she was a very, very tough patient. We fit her with scleral lenses just to get that initial, oh my God, relief so that she had that fluid on there. And then we slowly started working on the outside and the long-term impacts. This was her initially, one treatment in the middle and 2 treatments afterwards. Look at that reduction in that redness, in that rosacea. Look at her nose, look at her lid margins, but also look at her skin quality, how it's improved with IPL. IPL comes from dermatology, remember, so it has also an aesthetic component to it. Look at this gentleman's rosacea after 2 IPL treatments. Look at this lady after 3 IPL treatments. We did this for purposes of dry eyes, but look at the aesthetic here improvement. We have that structural improvement in Christine's glands there. Radio frequency. So this is skin tightening. We are regenerating collagen and getting rid of inflammation. Okay. Different approach. This is colorblind. So you could do it on darker pigments, whereas IPL is done on lighter pigmentation. Let me show you a couple of cases here. Satin came in and she was just, oh my God, my eyes were miserable. She was this young girl and she was just like, and I said, okay, here's everything that we need to do because you've got so much dry eyes coming from so many different places. And I pulled out this really long plan for her. After we did 4 rounds of IPLs, or sorry, radio frequency, she was like, I'm actually really good. I don't think we need to do the other stuff. And in the bottom, you can see the progression. You can see her glands are straighter. They're not as congested here. Look how they're cleaning up. This is a very short time period. I usually tell people, okay, after you're done your treatments, we need to give it more time for everything to allow the collagen to actually be formed. So it takes time, more before and afters. I used radio frequency on this gentleman that had all of these styes and he was like in pain. He's like, I can't even open my eyes. And I couldn't use IPL on him because of his skin tone, but I used radio frequency and was able to solve that. Lots of aesthetics things that I can show you, but I really want to get to a few more things. When we talk about expressing after IPL and radio frequency or expressing in general, it's about heating those glands and then getting that meibum out and that stuck oil out. And there's lots of different ways that you can do this. I prefer having a proper method than, like I told you, squeezing those glands. That's not where I want to be. Okay, we know about things to control inflammation, whether we're looking at cyclosporins or steroids, but I want you to also be thinking about Mibo. Mibo is a new product that you guys have, which is a protective layer that creates a protective shield over the cornea that prevents evaporation. Okay, really exciting drug. You have it, we don't. Use it. Let me know what you think about it because, I've been hearing wonderful things about this. Biologics are autologous serum and PRP and amniotic membranes. These are using our own natural body to get growth factors that are going to help repair the surface of the eye. There's a difference between autologous serum and PRP. And what the main difference is, we take blood and we centrifuge it. And when you centrifuge it, and first with autologous serum, what we do is we cause the blood to clot. And we cause the blood to clot all the platelets in the red blood cells come together and you get left with a serum. That serum doesn't have any of the platelets in it. And that serum is what we use, and we dilute it with saline, and that's what's create autologous serum. With PRP, we don't clot the blood, we centrifuge it, we separate it, and it separates into 3 different parts. So that middle portion there, which is the plasma that has the platelets still in it, that is what's extracted, and it's purely extracted. There is no saline that is released from there. That is full of growth factors because platelets are full of growth factors. Jumping along, this is a case by Dr. Mania Madan where she used PRP over 3 months with this post-LASIK patient, and look at how it just cleaned up because those properties within the PRP really helped. Amniotic membranes, you guys know about amniotic membranes. Here's all the ways that you can use it. There's 2 different types of amniotic membranes. 30 more seconds and I'm done, I promise. You've got Procara and the different forms of Procara, and you've got dehydrated amniotic membranes. Amniotic membranes I use a lot, especially the dehydrated ones, because they're so much more comfortable for our patients. Remember, when you're using these, you've got to treat the underlying condition first with the drops and then use this to repair, prevent scarring, that sort of thing, okay? Last is LLT, red light therapy. There are more devices that are coming out in Canada and US that are available. More to come. We are starting to explore this, and that's sort of my next area.